My name is Shelagh Leahy. I'm a general practitioner from Yarmouth, Nova Scotia. I've been practicing there since 1976, except that I took a year off when I was 50 and a year off when I was 60 to play, all funded by my fee-for-service income. And I'm here today to talk to you about the payment models that physicians operate under. There's three kinds of ways that physicians practice. They practice either as a solo practitioner by themselves, they may be part of a partnership or a group, and they may, in more recent years, be part of a collaborative practice, which is a little bit of a more, it's a model that involves other kinds of health practitioners rather than just physicians. The first practice type I'm going to describe is solo practice, and that's how I started in '76. And the lovely thing about being in solo practice is that you have control and freedom. You get to set the hours, you decide who works for you, what kind of a practice it'll be, and you can determine when you're going to take a leave from that practice, as I did, and when you're going to work extra hours and extra time to respond to the needs of your practice community or to make more income. There are some great things about it, and as I mentioned, the two highlights for me are freedom and control, and you have a real opportunity to design the type of practice that you want. But with that freedom and control comes responsibility. So you are responsible for all the costs and the bills. You're responsible for the patient load. So what happens when you want to take vacation or to take leave or you become sick? You're also responsible for hiring, firing, and running the business of your practice. And that can be stressful at times when your employee becomes ill or requires some time or leave, or you have to fire that person. So it's all on your shoulders, and that can be onerous for some people. I enjoyed it until I got to a certain age, and then I found that a different model worked for me. Second kind of practice that is quite common for people, and perhaps more so lately, is a group practice. The important thing about a group practice is not to assume that you understand what your partners want. So a group practice is at least two physicians, perhaps more, working together in the same space and providing care for a population of patients. The lovely thing about it, and the pro, is that you can share the load. You share the practice, perhaps, you share the costs, you share the administrative decisions, so it lightens the load for the physician. And it gives you some freedom of responsibility so that you can take time off, you can take a leave or go on vacation knowing that there is a physician back in the practice taking care of things. However, you need to be thoughtful about the fact that you will be wise to have a practice agreement. If you kind of make assumptions that everybody's on the same page as you are, you can get a nasty shock. So if you start off with a good practice agreement that everyone has discussed the various issues that might pop up, you have a much more collegial relationship. And there aren't the arguments and tensions that can be created by a miscommunication. The last and more frequently developed practice type that we're seeing in the last decade or so is a collaborative practice. And again, this is an enhancement because you add to your group of physicians other healthcare professionals, perhaps a nurse practitioner or a physiotherapist or a mental health provider, and that professional adds to the services that you can provide to your patient population. The good thing about it is that it gets the right person to provide care at the right time for that patient. The difficulty is that you need to be thinking about, so who's going to pay for that other healthcare professional? If it comes out of the pocket of the physician, that's a very expensive purchase. So usually in collaborative practices, there are different funding models that make all of that enhancement possible. So great to have the exchange with other colleagues, great to have that sounding board for a patient who's difficult, that you have another professional who can offer advice, but a little more complex when it comes to funding. Let's take a look now at payment models for self-employed physicians. There are three common ones. The most well-known probably is fee-for-service, where the clinician gets paid for each task or act that he does. The fee for that is negotiated by the Doctors Nova Scotia in collaboration with the Department of Health and Wellness. They negotiate a certain number of units for that service, and then that is adjusted on a periodic basis. The fee-for-service model also allows the physician to charge their patient directly for certain things which are not insured services, and they also have other agreements with such groups as workers' compensation. So together, the income that the physician receives is based on services that are insured by the government of Nova Scotia for patients, and then other income that comes from the patient themselves or other agencies who are willing to pay that physician for what he does. So there are some advantages for a fee-for-service compensation model. You can work as hard as you want and for as many hours a day as you want, and of course, for each of those hours you get further compensation. So you can actually do quite well under that model, but you have to think about the fact that it's somewhat limiting in terms of the services that you can offer and the time that you can offer to a patient. As well, when you're not working, you are not making any income. So that can be daunting when it comes to taking time for vacation or if you become unwell or unable to practice. The fee-for-service model has some downsides as well. Some people comment that perhaps you don't spend as much quality time with the patient as you should. And they also comment that perhaps we steer away from things that are not well compensated but good value for the patient because we are thinking always about the time that we are spending with the patient. So the next payment plan we're going to talk about is the APP, or Alternate Payment Plan. These are plans that are offered to physicians who are working in areas that may have a small volume of services needed to be covered, or that they are very labor-intensive, time-intensive, and can't be compensated on the usual fee-for-service model. They are negotiated by the physician with Doctors Nova Scotia and the District Health Authority and the Department of Health and Wellness all being partners in the agreement. The difficulty and the good thing at the same time is that it is not a salary position. So although you get paid every 2 weeks over the course of a year, there are no additional benefits that come with an APP. It does allow you to offer more time to your patient. It allows you to offer patients who are often underserved, for example, perhaps psychiatric services or so on, excellent care, but you are somewhat limited in the control that you have in your practice. There are set deliverables negotiated in this APP, so the physician must provide services for 37.5 hours a week, and they have to provide particular services that are negotiated. The freedom is not there that is available to the fee-for-service physician. The good thing is the income is very regular. It's available when you're on vacation, if you have to take a leave from the practice, and it tends to work out well for physicians who like that predictability. A third model we're going to discuss today is AFPs, or academic funding plans. These have some similarities with APPs in that they require shadow billing. They require that you provide a certain set service package that is negotiated. The negotiations for AFPs are with people who are working in academic medicine. So the academic medicine people from the Faculty of Medicine negotiate with the Department of Health and Wellness, and then with the group from the Capital District Health Authority /IWK. So all four of these parties work together to deliver a plan that will give a variety of services. There are clinical services, of course, but in addition they compensate the physician for administrative duties, leadership responsibilities, teaching responsibilities, and research. So a much more complex package than is covered by the APP. They are quite Byzantine. I use that word because the funding goes to the academic funding plan program at the Department of Medicine, and then the physician negotiates individually how much of the time will be spent in clinical services, how much in teaching, and how much in research. And this can be kind of onerous. On the other hand, it does provide the physician a wonderful opportunity to be compensated for their teaching and research. Both the APP and the AFP are currently being revised. This is a long-term plan to make sure that the deliverables or the set requirements that come from the physician and the payment models are representative of everybody's needs. Some physicians find it quite onerous, though, because they are required to keep track on a shadow billing format for the services that they provide, and this can be a little time consuming.